Pancreatic cancer can be caused by exocrine cells, which secrete substances into the pancreatic ducts, or endocrine cells, which secrete substances into the blood. 90% of pancreatic cancer is usually from the first group due to ductal adenocarcinomas, and it's really the focus of this video. Usually, patients present late with advanced disease, complaining of jaundice and weight loss. These have the worst survival of all gastrointestinal malignancies. On the other hand, endocrine tumors present with excess hormone secretion, for example insulin, glucagon, or gastrin, and are mostly benign. If we look a little bit closer at the pancreas, it has a head, a body, and a tail. About 70% of tumors are located within the head of the pancreas, 10% are in the body, 10% are in the tail, and 10% are multifocal. It usually metastasizes early to lymph nodes, then to the peritoneum, and to the liver via the portal vein. Distant mets are usually found in the lung and the brain. Some key risk factors include chronic pancreatitis, cigarette smoking, age between 65 to 75, obesity, type 2 diabetes, and a positive family history. Let's break down the clinical features in terms of signs and symptoms. The most common symptoms are usually constitutional ones, including weight loss, anorexia, and weakness, with about 80% of patients experiencing these. Constitutional symptoms usually indicate advanced disease, and rapid weight loss is usually associated with unresectability. Abdominal pain occurs in about 60% of presentations. Its site is generally epigastric. Its onset is usually insidious, and there for 2 months before presentation. The pain of advanced pancreatic carcinoma is characterized as a severe, continuous, and typically deep and gnawing pain. It often radiates to the sides and through the back, and it's usually associated with nausea and sporadic vomiting. The timing is usually nocturnal and poorly relieved by analgesics, but sometimes eased by leaning forwards, sitting up in the pancreatic position. One common sign is jaundice, which occurs in about 50% of presentations and is associated with pruritus, pale stools, and dark urine. Early on, this is often without pain and develops over a few weeks. The jaundice is caused by common bile duct compression in its course through the pancreatic head. As a result, the proximal bile duct dilates and the gallbladder distends. Courvoisier's law states that jaundice and a painless palpable gallbladder is very likely to be pancreatic cancer, as gallstones causing obstructive jaundice will be painful on palpation. Other signs of metastatic disease may be present, including ascites and left supraventricular lymphadenopathy, known as Virchow's node. Keep in mind that the initial presentation of pancreatic cancer really varies according to tumor location. Pancreatic head tumors will compress the common bile duct in its course through the organ. This makes presentations with jaundice, steatorrhea, and weight loss much more common. To investigate pancreatic cancer, consider a structured approach, including blood tests, imaging, and definitive tests. Consider blood tests including liver function tests. Abnormal LFTs are associated with a degree of obstructive jaundice. There are also biomarkers for pancreatic cancer, including CA19.9, also known as carcinoembryonic antigen. It's mostly helpful for preoperative staging, identifying recurrence in patients who've undergone resection, and in assessing the response to treatment. Consider imaging, including an ultrasound. This will seek masses in the pancreas and liver, dilated bile ducts, and stones in the gallbladder. Primary imaging is usually just done with a pancreatic protocol CT scan. This can show tumor extent, the presence and volume of liver metastasis, and help determine the feasibility of surgical resection. When an ultrasound and CT indicate a pancreatic head carcinoma might be resectable, endoscopic ultrasound can give added detail. In this, an ultrasound probe is positioned in the second part of the duodenum via a gastroscope. Needle aspiration sampling of suspicious lesions can then be performed via the gastric lumen for cytology. The management of pancreatic cancer should really be based on the extent of disease. The only potentially curative treatment is surgery via operative resection. Alternative treatments for more extensive disease should really include palliation. Chemotherapy and radiotherapy may be used as palliative treatment as well as in the adjuvant setting with surgery. Surgery can also have a palliative role. The Whipple operation, also known as a pancreaticoduodenectomy, is the standard type of operation where resection of the pancreatic head is indicated. It is a major undertaking with high operative morbidity and mortality. For the palliation of pancreatic cancer, pain management is key. Analgesia can often be relieved by permanent celiac ganglion block performed percutaneously. Obstructive jaundice can usually be relieved by inserting a biliary stent via an endoscopic retrograde cholangiopancreatography. My mnemonic for pancreatic cancer is based on its classic triad of clinical features, which are pain, weight loss, and jaundice. I remember that a patient that's crippled, whittled, and looking like a skittle needs a whipple. This short rhyme tells you that if a patient is crippled with abdominal pain, whittled with weight loss and cachexia, and yellow as a jaundiced skittle, they can only be cured surgically with a Whipple's procedure. Thanks for watching Townsend Teachings. Please hit the notification button and subscribe. Thanks!